Hello, and this is the MGH brain-PBM clinic, and I'm Paolo Cassano. Today is February 5th, 2021, and thank you for joining. So this is our discussion with Fredric Schiffer, MD, Assistant Professor in Psychiatry at McLean Hospital, who has some interesting data to present today on opioid dependence. Fred, you're known to many of us, so please take it away with your presentation. There will be a chance, of course, for discussion. If there's any pressing discussion, I think Fred doesn't mind interrupt, but otherwise we'll move forward with the case and your comments.
So share the screen. Okay, so this talk is going to be a case presentation, but it's also going to be a description of a psychological theory. Personally, I think it's the most important psychological theory that you've never heard of. And I've been working on it for 30 years. And the theory gets applied with biophotomodulation, and the results that we have in my practice and in two recent randomized clinical trials have been quite good, as I'll show you. So it's sort of a multi-part presentation. Let's see. Okay, so I have a conflict of interest. I got patents for the methods that I'm going to describe. I sent them through partners, and partners elected to relinquish. They didn't want to pay for the patent prosecution, and so they've relinquished the patents to me. So I own two patents on the methods that are presented, and they also relinquished two additional patents that are pending. And then I started using this technique that I'm going to describe in my practice, and was getting really results that I found to be remarkable. And so after some consultation, I decided to apply for a NIDA SBIR grant, and we did get that. And we're now, we've applied for the phase 2. And so in order to do that, I had to form a company. So I'm now the president, CEO, and founder of Mindlight LLC. So therefore, I have a conflict of interest with McLean and partners. So that I don't falsify data to enrich myself. Here's the case report. This patient first came to me in June of 2013. So he's been with me for a while. Well, why don't I just read it as I have it here. A patient at that time was a 32-year-old divorced white male who was snorting 400 milligrams daily of oxycodone for 8 years. When he came to see me, he was in withdrawal, and I induced him onto Suboxone. He has two sons with whom he's always been close and loving. and had a very contentious divorce around the time he entered treatment, and the contention with his ex-wife continues to this day. He had no psychological insight into his problem, except that when he was prescribed oxycodone 8 years earlier, he discovered, and he was prescribed it for an injury. He discovered that he liked it, and he said, it calms my anxiety, makes me feel like I can do anything. Without opiates, he would feel down and moody with anxiety. From my notes, I wrote, he feels very anxious, anxiety takes over his head at this moment, doesn't know what the anxiety is about. The patient did report that as far back as he could remember, he suffered anxiety and depression. His parents were divorced when he was 3 or 4, doesn't remember his father. A year earlier, he had a 7-day detox at a local hospital, but soon relapsed on no psych meds, not treatment when he came to see me. He had in the past a trial of buprenorphine, and it was helpful, but he relapsed on that. So he sees me every 4 weeks for 30 minutes. That's more for economic reasons. His urine drug screens have always been negative, except one positive that occurred 2 months after beginning therapy. I don't think that was a real relapse. I think it was, a brief relapse or brief use. I've been treating him continuously with buprenorphine, Klonopin as needed, and Adderall. He has some attention problems. There's more history to come, and what I feel is that with addiction and with all patients I see, that the psychology is really critical, and we're going to see how this psychology is important and relevant to his addiction. And a lot of people think of addicts as addicts, and sort of it's a genetic disease or a chemical disease. And I find that I don't have any addicts in my practice or any alcoholics. What I have are people with PTSD, and we'll see what I mean as we go forth. So dual brain psychology is my psychology. And I'm going to have to walk you through that quickly. It comes out of observation that I had early in my career that even though I was an in-depth, dynamic psychiatrist doing psychotherapy, I didn't really see ids and egos in my office. And but what I did see was that patients seem to have a immature personality that was neurotic or disturbed, and then as they got better, they had a mature personality, and then they would regress again, and they would revert to this immature personality, and I tried to discuss this with my colleagues at McLean, and no one was really interested in it, and then I reread the split brain studies that I had read in college, and had a new understanding of it. And so I'm going to review the split brain studies quickly. Essentially, the corpus callosum down here is cut. And this is a surgery that I'm sure most of you are familiar with this, is done for intractable epilepsy. If you put something in the left visual field, it goes to the medial part of the retina. The retina, it happens to be divided vertically between 60% that crosses over to the other side. And in a split brain patient, he can see, he or she can see the image presented to his right visual field. The talking side, language is in the left brain, almost always, and in all the split brain patients, it was always in the left brain. And so the patient would say, I can't see it. And the instruction was use your left hand, which is controlled by the right brain, and reach into this box here, which has 10 items in it, and take out the one that we show in the picture. And the patient can pick it out just like a normal person. It's a very easy task. If you put the box on the right side, and his right hand, which is connected to his left brain, tries it, he has no idea what to pull out. And Dr. Sperry, who won the Nobel Prize for this, Roger Sperry, showed a female split brain patient a photograph to her right brain, showing it to the left visual field, and she started really giggling. And this is a very famous case. It's in the literature, and her left brain said, they asked her why she was laughing, and she said, "You've got a funny machine, doctor." She had no idea why she was laughing. What Sperry had done was he put a picture of a Playboy nude, which I'm not permitted to show now. I don't know what the nude was, but the patient found it inappropriate and found it humorous, because Sperry was this very dignified doctor with a white coat on, and it is funny. But the left brain had no idea what had happened. After the colostomy, there's a syndrome that lasts about 2 months, usually, until the left brain takes over control, where the two hands can fight with each other. They can slap each other. And one patient wanted to smoke a cigarette, and his other hand kept putting it out. And so you have really two minds. And that's really the important takeaway from the split brain studies, that when you cut the corpus callosum, you create two minds, two intact minds. And if you had only a quarter of a brain, you wouldn't have a mind. But a whole hemisphere can support a whole mind, and you can talk to the right brain. And there's a study that I went out to California to Sperry had died by this time, but I worked with Joe Bogan and Irene Zeidel, and we did 2 split brain patients, and I asked, how much do you feel? And on one side of the screen was a word that was positive, like honest, and on the other side of the screen was another word, and they were randomized, and there were half negative words like dishonest or unhappy. And what we found was that there were consistent answers, and they answered with their fingers pointing to pegs. So because of the consistency, it showed that the different hemispheres in these split brain patients were accurately reporting responses to my questions about how they felt. So this was the first psychological examination of 2 split brain patients. And what we found in this one patient was that his right hemisphere had a higher opinion of himself than his left hemisphere. His left hemisphere responded with significantly more negative answers, and his right hemisphere more positive answers. So dual brain psychology points that one brain hemisphere is associated with a mind that is more troubled due to past maltreatment or traumas, and that another mind within the same person is less affected by past traumas and is healthier. So here's my book that came out 23 years ago, and the subtitle was The Revolutionary Science of Dual Brain Psychology. And the revolution never happened. it was put down at the gate. Essentially, what I found was I was reading some literature, and it was a German group that was purporting to show movies to one hemisphere or the other in intact people, people who did not have this cut. And they found different mood, different affect changes due to an upsetting movie, and it was very hard to follow the protocol that they were using. They were tracking eye movements and masking a computer screen, and after reading it a few times, I figured out that they were showing the movie to one visual field or the other, and I figured, on my budget, I could do that. And that was these glasses here. And the Academy, I think, was turned off by these crude looking glasses. And so we've devised a computer test that does the same thing as this. And I'll talk a little more about that. But essentially, if you have the person look out their right visual field, the image goes here, and it does cross over, but it does stimulate the contralateral hemisphere. And I'll show you later an fMRI study that shows the contralateral hemisphere lights up like a Christmas tree while the other's dark. I'll show you that. That's coming. But this is so I would have the patients wear these glasses, and my first patient who I tried it with, he was just using his hands. He was a Vietnam vet who had been on 4 tours in Vietnam, and I didn't respond to it, but I asked him, and he said, his face screwed up, and he said, that plant behind you looks like the jungle. I said, really? I said, why don't you look at the other side? And he said, oh, it's a nice looking plant. And I knew I was in business. And so I would use the glasses in therapy and have the person look out one side or the other, and eventually get the healthy side to try to help the troubled side. And I could talk to the troubled side. And we could have the troubled side look out the other side. And so this became the treatment aspect, the psychotherapy aspect of dual brain psychology. And I want to show you a picture here. After my book came out, I was on 2020. And I just want,
Tonight we bring you word of an amazing medical discovery. It's not a bio... Goggles indeed arouse the right brain and vice versa. I observed a volunteer test.
That's the younger Dr. Schiffer.
It was his first time trying the special goggles. Neuroscientist Carl Anderson asked Chris to rate how anxious he felt while looking out goggles that were taped to allow him to see only out the extreme right side.
How much anxiety do you feel now? None at all? A mild amount? Moderate amount? Quite a bit? I want to say an extreme amount. Okay.
Chris also reported that he felt extreme tension and anger while looking to the right. But when he put on goggles that let him look out to the left, his reactions were quite different. When asked to rate his anxiety level,
I don't want to say I feel like none, but I don't feel like really anxious.
Dr. Schiffer asked Chris to retry the right-looking glasses that seemed to provoke him.
Tell me what you're feeling.
I'm feeling like Like I want to take these glasses off. I mean, but, they're making me angry.
I want you to try this other pair.
Okay.
These glasses allow Chris to again see out the left side, and they seem to comfort him.
This side feels more easygoing. More,
Mm-hmm.
Now, so that's his right brain
Happy-go-lucky
that feels better.
Mm-hmm.
personality. The other side, I want to go to war with something. You know?
Go to war?
Yeah.
What Chris has just demonstrated in the lab is what Dr. Schiffer.
So, so here's the premise of the theory that one side can be healthy and the other side can be mean, like this son of a gun here, and that there are different mental properties on each side. And what I mean by that is, if I have somebody looking out the glasses, if they're looking out the left side, they're apt to see me, or you know, it could be one side or the other. But on their negative side, I look critical, and that came up by itself. So this is just showing that there's sort of an interaction between the two sides. And you may wake up feeling well, and then later in the day, you're kind of irritable, and you go back to feeling better. And so I look critical. He doesn't like himself, and he may get drug cravings. And out the other side, I look supportive, and he likes himself, and the drug cravings go away. And so it's a whole. That's why I call it a personality change, because it's not just, you know, like his depression's a little better, or, but it's really as you saw in that example from 2020. You know, he was sort of a different person depending on the side he was out. He had the same Social Security number and the same address, but quite his behavior would have been quite different. And people who use alcohol or drugs, or are depressed, or hypomanic or whatever, you'll see differences out the two different sides. And so unfortunately, I didn't move the slide over, but this picture here is, this is an fMRI study of 7 people from our lab at McLean, and we're combined in it. And so looking at the left visual field stimulates the right brain, and the left brain looks sort of like New York in a blackout. And if you could see the rest of the slide, you see that it's just a mirror image of this. So he looks out the right side and looks at the right visual field, which then stimulates the left visual field, which looks like this. And the people wore these goggles in the scanner, and they'd look for, I forget the amount of time now, but maybe a minute out one side, and then they'd go to the other side. So in my clinical practice between 1994 and 2017, I used taped goggles, or now I really just use a letter envelope. So if I have one here, yeah. So I can just have a patient go like this or like that, and it all does the same thing. And it's easier to use with an envelope, and you get the same effects. And about 80% of my practice respond to this, and usually people who don't respond later in their therapy. And I think that there's a repression that's going on that prevents the response. But there's a high rate of response amongst my patients. Amongst neurologists, no one has ever responded. So I don't know what that means, but anyway, with the case that I'm presenting, he consistently felt 2 or 3 points less anxiety out of his left visual field, which again, so far I've mentioned 3 cases that where the right hemisphere was more positive. And when he looked at the right visual field, his anxiety would be between 7 and 10, usually around 10 actually. And he'd have cravings out the right visual field. And again, all the bad stuff is always on the same side. And it's a trait for the person. It varies between people. I think I have a little more to say about it, but it's about 50-50 in the population. So here's some additional history. He began to remember his father, and initially he denied any memories. I don't know that they were, well, they may have been repressed memories. His father was a violent alcoholic who would beat mother. And once when the patient tried to intervene, father threw him down the stairs and he broke his leg and was forced to tell the emergency ward doctors that he slipped. On other occasions, father would throw him down the basement stairs. The parents divorced when he was 3 or 4 years old, and he and mother returned from a vacation and found that their house had been burnt down by father. So my hypothesis is that trauma is more located in his left hemisphere. And so we use the term in my group at McLean, hemispheric emotional valence. And it's a little different than what's used in the literature. Personality change with negative emotion and cognition related to past traumas, a negative view of the world and of themselves. It's not the usual right hemisphere is more emotional or more withdrawing or more negative, which is the usual way that the Academy thinks about the emotional status of the 2 hemispheres. I initially thought that I would find all the negative emotions in the right brain, but that's not what I found. And it's not what the German group found either, just as a coincidence or whatever. What we found is the positive hemisphere could be either left or right, and not the usual left good, right bad. And then we have interesting anatomical evidence. We have this paper now in submission at the Journal of Psychiatry Research. And I gave a computer test, which is like the goggles, but it's just to cosmetically clean it up a little. And I gave it to 50 patients who had come into Dr. Teicher's study of childhood maltreatment. These were people who were asymptomatic, but they had a history of maltreatment. And there were some controls in the group as well. And so we measured their hemispheric valence. And what we found was that if the left hemisphere was your good hemisphere in these people, that we looked at 4 areas, and these 3 were positive. From the literature, we selected 4 areas. And the lateral index, which is the left minus the right over the sum of the left and right, was highly significantly associated with the hemispheric valence. And the hippocampus and the amygdala were also statistically related to the hemispheric valence. And it turned out that what we found was that if your left was positive, your left accumbens was larger than your right, and your hippocampus was larger on the left and smaller on the right, and your amygdala was smaller on the left and larger on the right, and vice versa. if your right hemisphere was positive. I'm sorry, if your right hemisphere was negative. And so because there were differences in the side in which a person felt more positive or more negative, I approached Alvaro Pasqualeone at Beth Israel Hospital, and to my surprise, he took the goggles, and the idea was to test the patients prior to left-sided TMS, and TMS is always given when it's given an activating a dose of 10 hertz on the left side of the forehead. And if you want to know why it's always given on the left side, no one knows. But that's the standard of practice that I have tried very hard over the years to get somebody to treat the right side in appropriate patients, and no one would do that. And the results we got were blocked, and I couldn't get Alvaro to get back to me. So I saw him after a talk he was giving, and he said, you know, those glasses, they work. And so he saw in 37 patients, 35 felt more depressed on one side than the other. And so what we found was that in those who had the positive hemisphere treated with, in other words, had a left positive hemisphere, they had a 45% reduction in their Hamilton score. Those who had a negative left hemisphere still had a reduction, but it was only 7%. And it was highly significant. I wanted to see if I could find some other way of stimulating the positive hemisphere without RTMS. I couldn't fit, I couldn't carry the machine up my stairs. So I thought of using near-infrared light. I knew a little bit about it because I'd done some work with near-infrared spectroscopy. So I made a cold call to the Wellman Center, and I got passed around a little bit. It was maybe on the third call, and I was introduced to a guy named Michael, and that was Mike Hamlin, and he and I got to work, and we did the first study using transcranial photobiomodulation for a psychological disorder. He had been using it for TBI, and there was a group in California that was using it for stroke. But this was the first for a psychological disorder. And I wanted to, I was interested in using it on the positive hemisphere, but I didn't want to get tangled up in the IRB having to explain my theory that no one else understood or was interested.
Sounds familiar.
And so eventually, we published this study, and essentially we had 10 patients, half male, half female, and it turned out that 7 had a history of substance abuse, 1 alcoholic and 6 opiate or opioid users. None of them were actively using or had used in a long time, but they happened to have that history. So it sort of fit in with my interest in opioid use. This is a patient actually during the study, and these 2 patches measure near-infrared spectroscopy. That's a Somanetics device that I had purchased a few years earlier. And then this is the LED with a heat sink and has a computer fan on top. And so I'll go over just some of the findings briefly. This is an increase in cerebral blood flow. And someone called Mike and complained that the device we were using would interfere with the near-infrared spectroscopy, and so all the data were falsified. So I went back and looked at the data, and hadn't done this when we did the paper, and I separated males from females. And males did much better than females. So it confirmed that the light was not affecting the near-infrared spectroscopy. But interestingly, we found a much higher increase in blood flow in males than females had. We measured the Hamilton Depression score 2 weeks after a single treatment. That's a 4-minute treatment. Well, it's I guess 8 minutes because we did both sides, and it went from 29 down to 11, which is a huge drop. It's much better than you'd get with Prozac. And then
That's amazing. That's after one treatment?
Yeah, one treatment.
How sustainable was that?
And then it started to come up at 4 weeks, but only came up to 17. So and males did better than females. And then this was anxiety. It went from a Hamilton of 23 down to 8.1. And you see that it was pretty uniform throughout the group. And again, males did better. And these were bilateral treatments, and the results were not noticed by the patients. In other words, they scored well on the Hamiltons, but they didn't report. I spoke to them after, actually, when they came in for the follow-ups, and they didn't report feeling less depressed or less anxious. The only guy who reported any difference said, well, maybe it helped. My ex-wife isn't bothering me as much. And that was about it. But so there were very strong results using the depression scales and anxiety scale. And none of the patients had cravings or use either before or during or after the study. So my interest all along was in unilateral transcranial biophotomodulation. And I focused on opioid use disorder for 2 reasons. One is that it happens that a lot of patients in my practice came to me, like the case I'm presenting for opioid use disorder. By the way, he has, other than that brief slip 2 months after he began, he has never used anything since then. We still work on his trauma. So that's really why he's in treatment. And I leave him on buprenorphine because it's very hard to get people off it, and he feels like it helps his anxiety. But I don't really have him on it for opiate use.
Yep.
So getting back to the patient, so my note, so this is from my notes, we discussed his father, and the patient became very agitated and anxious, remembering his trauma with his father, and his father's moving to an area close to where he lives. This is presently, about a year ago. Then we decided to do a light treatment. Before the treatment, the patient reported his distress about his father was 10 out of 10, and he felt terror in his body, which was visibly shaking. I gave him a light treatment, and within a few minutes, the patient began to feel more relaxed, less frightened, and by the end of the treatment, quite relaxed in his body, quite normal. I thought it was quite amazing, although I see this every day. I discussed with the patient that his light treatment is something for him to learn from, and to learn that he or the adult side of him can bear his trauma. And so this is, I have a tape of our session. This is a transcript of the tape. So before the treatment, I said, so looking at this, I have a photograph of a very angry man. So looking at this angry man, tell me what you're feeling. He says, feeling scared. I said, how scared? Say from 0 to 10. I'd say 8 or 9. Now, I noticed that you seem to be shaking. Now, by shaking, his leg was going up and down with an amplitude of about 1 inch. And patient says, yeah, I know. It's not because I'm trying to do it on purpose. And I said, I know, but it's an example of how stressed you feel. Yeah, extremely stressed. Let's try and treat you. So I treat him, and I'm treating his right hemisphere, which is his positive hemisphere. And it takes about 2 minutes to get an effect.
Fred, when you say positive, do you mean it's the hemispheric dominance? So is he left-handed?
No, it has nothing to do with hemispheric dominance. When he looks out one side or the other, when he looks at his left visual field, I look friendly, and his cravings go away, and he feels much less anxious. When he looks out his right visual field connected to his left brain, I look somewhat threatening, and he gets very, very anxious. He gets physical symptoms. So that's what I mean by the positive hemisphere. Okay, it's based on the visual test. You also can take the light and put it over one side or the other and determine which is positive. You'll get the same response. The light is the same as the envelope, but it's on steroids. The reaction is much more, it's 10 times stronger and lasts long. It's just
sorry if I interrupt. I just wanted to tell you that we have about 10 minutes or a little more than that if you also want to present your data.
Yes, okay, why don't I do that? So he stopped shaking and felt relaxed. Before I got the grant, between applying and getting the grant award, I did a self-pay study where I had people come in for 3 sessions, and they got either sham or active. It was a double-blind study. At 1 week they would get sham, the next week they would get the opposite treatment, and then they came in for a follow-up. After the active treatment, there was a 55% decrease in cravings. We didn't, most of the people were not using, but they had cravings, and it was highly significant and better than sham. We also got reductions in the Hamilton scores. There was a 42% reduction in Hamilton score. I treated the left and right side with the light off over here. There wasn't any difference between how they had in their cravings. With the light on, there was a big difference favoring the positive hemisphere. So in the second randomized controlled trial, which was supported by NIDA, we treated 37 patients. 66% were done at my startup, and 33 were done at McLean. And patients received active or sham treatment twice a week for 4 weeks, and then had a 3-week follow-up. And this shows that we zeroed it. This is the craving score, which is a standard test for cravings, zeroed. And then it shows that as they get these treatments, there were 2 treatments a week for 4 weeks, and then 3 follow-ups. So this is where the follow-ups begin. And both McLean and MindLight had very similar benefits. And this is about a 75% drop in cravings. The sham group at McLean did a bit better than at MindLife, but not, but both did much better than the active treatment. And with a mixed model, it's off the chart. And we we weren't trying to study use, but about 40% of the patients were using or used during the study. And so this is the amount of decrease in use. And during the active study, there was a big decrease in use among those who were using, not so with sham. And this shows the same thing. There was a big difference in use. And this also is, this is days of use. The other was days times the amount. And these are urine screens. So there are more positive urine screens in the sham group than in the active group. This shows that 8 patients were on Suboxone, 11 were not. Of those who were on Suboxone, that's pink, they did about as well as the other group. But what this is showing is that this treatment can be used as an add-on to people who are on Suboxone. They got much better over the course of the treatment. And it worked in people who weren't on anything. And nobody got other treatment. These were people who came from Craigslist. And so all they really got was a 4-minute light treatment. And this compares unilateral with bilateral. And so the findings are based on dual brain psychology, and they reinforce dual brain psychology's premises. And they show that unilateral TBM dramatically reduces opioid cravings and use. And these are 2 recent papers that I have out. And so I'm sorry to go over.
Thank you so much, Fred. This was really interesting. Would you mind showing one more time the slide, unilateral versus bilateral? Because I think that was your comparison group, is that right? There wasn't a group on just stimulation of the negative valence side or hemisphere, right?
Okay, I'm just trying to find my...
But meanwhile, I don't know if anyone else has questions or comments. We have a few minutes.
Can you show me what the device looks like, and is it available commercially for use by physicians?
It's not, but we're working on that, and we've submitted to the FDA, and I'm working with a device company. Let me see if I can go back here. So, so are you referring to this here, Paulo?
Right. So this was so there was a 3rd arm in your study. So unilateral positive valence hemisphere sham, and then bilateral. Is that what that means?
Well, no, it really wasn't a full study. It was in the study where I gave either sham or active, and then they came back the next week and got the opposite. When I gave the active treatment, I treated the negative hemisphere first, and then asked what their cravings were, and then treated the positive hemisphere, and there was a significant difference in reduction of cravings. The cravings did go down with treating the negative hemisphere, but very slightly. And when the light was off, there was no difference. So this was not a proper study would be to have a group that gets a bilateral treatment and a group that gets a unilateral treatment. And I have not yet done that.
But your experience is that if you treat both hemisphere, at least in your clinical practice, you kind of lose some of the benefits that you would have if you treated just the positive valence hemisphere.
Yes, in the study that we did at MGH, we treated both sides, and we got dramatic decreases in depression and anxiety, but we didn't see the kind of changes I have reporting in this patient. He's about 55% of patients get these remarkable responses where his legs stop shaking. And so I do think that there should be a direct comparison of bilateral versus unilateral, and I have not done that.
Thank you.
Can I ask a quick question following
Please,
the
go ahead.
same direction? So how do you determine which one is a positive hemisphere versus a negative one? Because you were saying it's not definitely on the right is a positive, on the left is negative.
Yeah, that's right. It depends on the individual. Everybody's different.
Yeah, how do you determine which side is a positive?
You get an electric bill? Have you ever gotten a bill from the electric company? Okay, well then you can use that for a good purpose. You can put it up and block your eye like this. Now the secret is not to go like this. If you do the whole eye, as I showed in the diagram, you defeat the purpose of it. But if you block it for the, let me see if I can go back to the beginning.
Interesting. I'll read your papers.
Yeah. I'm looking for that diagram of the connection between the eyes and the hemispheres. I can't get there, but the way the eyes are connected to the brain, you have to look out just a hemifield, and then you have them look out one side versus the other, and if you have a neurologist as your patient, he won't see any difference, and but and it turns out that people with who come in with anxiety are going to be more apt to have a response to the just a simple envelope. So it depends on which side they feel worse on.
Thank you.
Any final comments or questions?
Yeah, could I ask a real quick question, Fred? I may have missed this, but I saw that you studied the bilateral and the unilateral on the positive side. Did you look at unilateral on the negative hemisphere?
Well, I stimulate the negative hemisphere in psychotherapy with patients.
You mean with the light?
It brings out their symptoms. They don't go crazy. Maybe if I, kept it on for a long time, they might, have severe cravings. But it's sort of like looking with the envelope out the negative side, they have more symptoms than and they feel worse.
Okay.
And so I do that in my practice, and I do it to bring out the negative side so I can talk to it.
So is the idea when you do bilateral is that you're stimulating both sides and they're having opposing effects, and that's why the net effect gets washed out? Okay.
I think so. Although you did get good effects with depression and anxiety. But you don't see these kind of patients say, "Boy, I feel good," and you don't see that with the bilateral. And I have patients email me after the treatment, and it lasts usually about 3 days where they can really feel a difference. And I think it really lasts about a month. but sort of subclinically.
Just a question here on the fly while we're wrapping up. Is the device you're using now in your practice still the Marubeni?
Yes. Yeah. Yeah.
So-
We're having a new one made that will be, more. It'll be a professional model and to get through the FDA. So
Wonderful.
we are aiming towards commercialization.
Well, thank you so much, Fred, and good luck. This seems very promising, and I think we're all very excited. Thank you all for participating today, and stay tuned for more sessions. Thank you.